Hello, if any of you can hear me, please, you can write in the chat that you are hearing me properly. I will have to start the class, otherwise we will run out of time. Okay, I will go to screen sharing. If there is somebody that can hear me, please tell me, yes, Dr. Angel, we hear you. Okay. Okay, I will start with screen sharing. Well, good evening, everybody. I will share the screen now. Okay. Let's see if I can accommodate in a way that I can show you the... Okay, I will be quick. We have only half an hour. I think that this is a topic that requires more than one class, but I will try to make it short. This weekend I was attending the Mechanical Circulatory Support Conference in the King Faisal Specialist Hospital in Riyadh, an amazing place. The journey from veno-arterial and veno-venous ECMO to long-standing ventricular assistant devices support. So to start with this, we have to understand that it's very important to understand how the cardiogenic shock works. And since many years ago, the Society of Cardiovascular and Angiographic Intervention makes a consensus trying to unify all the criteria to specify when a cardiogenic shock is happening and why. So there are 4 different kinds of cardiogenic shock. We can classify them in the vasodilatory shock, the wet shock, the mixed cardiogenic shock, the euvolemic shock, and the classic cardiac shock, where we have low cardiac index, high resistances, peripheral resistances, and elevated wedge. From this beginning, they classify the shock in 4 different stages, where the patient is relatively compensated, patient is at risk, where the patient is beginning the shock, the classic shock, the deteriorating shock, and the shock in extremis. So in this classification, please, I can hear some microphones. Please, if you can turn off your microphones, it will be easier for me. According to the hemodynamics, you can classify the shocks in the different grades of severity, but we can say that the shock in stage C to E are the shocks where the patient is in the worst condition. The capillary wedge is over 15, the PAPI index is less than 1.8, the cardiac index is low, under 2.2, and the cardiac power is low also, under 0.6. We will come to that later. From that alone, we can say that our cardiogenic shock, we are in a patient that is sliding down and decompensating into severe life-threatening stage. So the Society of Thoracic Surgeons, based on that primary consensus, started what is called the MACS patient profiles, which was developed to overcome the limitations of the NIHA classification in patients that are being evaluated for mechanical circulatory support. These MACS profiles were intended to discern relative differences of patients with advanced New York Heart Association class coming to 3 and 4. So we can say that if you look at this staircase, you will see that going from NIHA class 3 to 4, we can make an analogy with the INTERMACS going from 7 to 1. That way, we will say that the 3 most serious conditions are the INTERMACS 3, 2, and 1. In the Intermax 3, we are talking about a patient that is requiring a lot of inotropes and that will go into cardiogenic shock decompensated very soon. In the Intermax 2, the patient is already in high requirement of inotropes and maybe already requiring mechanical support intervention. In the Intermax 1, we have the critical cardiogenic shock, either an acute on chronic decompensation or a critical acute emergency, like it would be a heart rupture, trauma, or immense acute coronary syndrome. Here, the time is not enough, but here you can see an analogy between the Intermax profiles, the NIHA functional classes, and the stages of the American College of Cardiology. Since 2004, the American College of Cardiology is classifying the heart disease, the chronic heart disease, as a cancer like stage A, B, C, and D. D meaning it is a terminal condition that will require end-stage treatment, either palliative or transplantation. So this is just to show you that the Intermax somehow tries to unify three different classifications for acute cardiac disease or cardiac decompensation, let's say. So this is one of the first articles that was published in 2016, and it has been updated every year. Actually, in the conference where I was this year, they were talking about the Intermax Consensus 2023, okay? So just for you to see, you will see in these lines that we are talking about patients with Intermax 4, 5, 6, and 7, which are the patients that have higher survival. So if you see the Intermax 6 and 7 have a survival of 85% at 12 months, but the Intermax 4, they are having a survival of 60% or less at 12 months. Okay, and the same happens when, which are the patients that survive when they don't get any ventricular assistance device rescue. And it is even worse for the Intermax, for the Intermax season 6 and 7, receiving without VAD rescue, they survive the 78%. But the Intermax 4 and lower will have a survival of only less than 40%. So now we will go to mechanical support, and that's what I wanted to say. The ECMO is just one of the many forms of mechanical circulatory support. But for me, it is not sense to give a class about ECMO without talking about the concept of cardiogenic shock, classification, and mechanical circulatory support. So when we come to the physiology and mechanics of ECMO, we are talking about extracorporeal life supports, or MACS, mechanical assisted circulatory support, okay? What is ECMO? ECMO is what is called extracorporeal membrane oxygenation, which is a form of extracorporeal life support. If we compare the extracorporeal with the corporeal, in the case of our body, the oxygenator is in the lungs. The lungs have many functions, among them oxygenation, gas exchange, and filtration. In the case of the ECMO, our oxygenator is a part of a circuit where we are making gas exchange and at the same time we are filtrating. But this is compared with the mechanical ventilator. In the case of a mechanical ventilator, this is an assistance to our lungs. But in the case of the ECMO, we don't have a ventilator. Instead, we have a sweeping machine, which is a combination of gas provided with velocity of flow and a mixer that will give us the concentration of oxygen. Okay? Initially, I have to tell the ECMO was initially prepared for pediatrics. In this case, I'm going to show images of pediatric ECMO, but it is applied also to adults because the ECMO originally was planned for children in the end of 70s, beginning of the 80s, and posteriorly, in the last 15 to 20 years, it has been applied in adults. So when we do the cannulation for ECMO, this applies to adults and children, we have a special cannula that is called venous cannula. And this cannula has, and in the case of mechanical support for the ventricle and for the heart, we have what is called the veno-arterial cannulation, which requires actually two different cannulas. For the venous cannula, we can have one cannula that is called combined cannula, where you have one suctory lumen and an injecting lumen that will give us the perfusion for the oxygenated blood. But in the veno-arterial, this is not enough. We need a venous cannula that will make the suction of the cardiac output, and the arterial cannula that will give us the positive cardiac output in the left circuit. Okay, and the images are not perfect, but we can see that in the case of children, you can put it through the subclavian or through the carotid artery, the arterial cannula, and the venous will go through the jugular vein to the right atrium. The problem is when we are using ECMO that we have poor oxygenation and poor oxygen delivery. So we need to use this machine, which goal is oxygen delivery to the tissue. This is a drawing of how the machine is in children, but to simplify it, we will see that when we use ECMO, we have a drainage cannula that usually for the veno-arterial ECMO in general, the drainage cannula is going from the inferior vena cava, okay, coming close to the right atrium. It will have a ultrasonic bubble detector. We have a bubble trap that will tell us if there is air being injected in the circuit, which is very important to avoid. And then we will have the oxygen sensor, and we will come to a pump that this pump can be a roller pump, centrifugal pump. Nowadays, there are pumps called levitating pumps that are faster and don't create friction. So from this pump, the blood will be pumped, as the name says, to the oxygenator. The oxygenator is the filter that will perform the gas exchange. The gas exchange will be coming from our oxygen provider, which is giving us the mix between air and oxygen. With the concentrator, we can decide how much oxygen we want in the mix. With the sweeper, we can decide how high is the flow of oxygen, of gas that we want to come to the filter. Okay, sometimes we need higher flow because we need to wash out CO2. Sometimes we need lower flow to give good time to the oxygen to pass through the filter to properly oxygenate the lungs. And at the same time, this oxygenator is connected to the heat exchanger because the blood is going out of body, going low in temperature, and the heat exchanger will help us keep the core temperature in our patient. And then we have a return cannula to this going to the arterial end that will end up in the ascending aorta, which have also a bubble detector. So these are the basic components of an ECMO circuit. Now, when we come to the cardiopulmonary physiology, we have to keep these concepts fresh: oxygen content, oxygen delivery. Our body will receive the oxygen, our body will consume the oxygen, and at the same time produce CO2. Okay, I will focus in one concept, that is the oxygen consumption and delivery. We have to know that how much oxygen the body is using, the difference between what is delivered and taken up by the tissues and what returns to the right side of the heart will give us an idea of how is our patient's metabolism. Normally, the oxygen delivery is 4 to 5 times the amount of what is being consumed. Okay? That's why we are measuring in these patients, the cardiogenic shock patients, and in general shock patients, the central vein saturation. Because if there is good oxygen delivery and the oxygen extraction is not that high, we will have 65 or 75% and over in the level of vein saturation. But if we begin to drop the central vein saturation, the mixed vein saturation, that means that the oxygen consumption is increasing. There will be lactate augmentation. our patient will enter into metabolic acidosis, which means that there is bad tissue perfusion, which is telling us that the shock is going downwards and our patient is going to crash or is already in a crash, and we have to recover and pull out from that situation. I hope this is being understood. In the case of VA ECMO, the good thing is that the VA ECMO will provide excellent oxygen delivery. It will help with, it will do right atrial drainage. It will give aortic return of the blood. It helps us to sustain normal hemodynamics, to recover our patient to normal hemodynamics when we have bad left ventricle function. It will, the oxygenated blood is bypassing the pulmonary and the coronary arteries. And at the same time, this machine is bypassing the lungs' natural filtering properties. That's why the bubble traps are so important in the circuit of the VA ECMO. When it comes to hemodynamics, the VA, the veno-arterial ECMO, has non-pulsatile flow. The ECMO pump creates flow that is non-pulsatile. The systemic arterial pulse contour flattens when and there is a reduction of the pulse pressure, and unless there is myocardial stunning, severe myocardial stunning pressure, the veno-arterial extracorporeal life supports can run up 80% of the normal cardiac output. There will always be a part of the cardiac output that is going through the lungs and the right circuit and the lungs without being pumped by the ECMO. That's 20% we are missing. So we are relying on what the machine can deliver to complement the remaining small amount of autonomous or autochthonous cardiac output from the patient. So this is what happens when we increase the ECMO flow in our patient to do a veno-arterial ECMO. Initially, the patient has its own blood pressure. Then the patient is going into shock. We begin to increase the bypass and the veno-arterial ECMO, and the total systemic blood flow, you will see this is the cardiac output, liters per minute per square meter. We achieve a good cardiac output around 2.5 to 3 liters per minute per square meter, and the pulse disappears because the cardiac work is not being done by the heart, it's being done by the machine. We lose our pulse pressure. After the time when we are